Thank you for asking me to speak briefly on colon cancer. Of course, this is a vast subject and there's a lot to talk about, but I think over the next few minutes I want to give you an overview of what's considered to be the third most common cancer in the United States and essentially in the Western world. Globally, this cancer occurs in about 600,000 people annually. And it is more common in the Western world, and we believe that the reason for this has to do with the diet that we have. We have a diet that is richer, it's higher in fat, higher calorie, and these are risk factors that are associated with development of colon cancer. When we look at individuals that come from the Eastern world, even maybe my homeland of Iran, the incidence is less compared to the United States. But interestingly enough, when you take the same person and you have them immigrate to the United States, their lifetime risk of colon cancer increases to the same as an average American living in this country. This is a cancer that occurs over a very long period of time. It's actually, in majority of the cases, it arises from a growth within the colorectal area in the shape of a polyp. And typically, these are called villus polyps that have the potential of becoming cancerous. And we know, based on work that has been done now years ago, that this is a process that can take up to 10 years. And the majority of the cases actually occur in individuals that are greater than the age of 60. But there's about 3% of the cases that occur in a younger population, less than the age of 40. So if you want to reduce your chances of getting colon cancer, detection becomes very important. And this is one of the few cancers that we have a very unique ability to identify it at an earlier stage. And that would be doing either a combination of what we call fecal occult blood testing and sigmoidoscopy, or doing colonoscopy. The recommendations from the American Cancer Society is to start colonoscopy at age 50, unless there has been a relative or a first-degree relative in the family that has developed the cancer at a younger age. And in that case, the recommendations are to start at 10 years younger. So for example, if my uncle was diagnosed with colon cancer at age 45, then it would be prudent of me to start my screening at age 35. And this is a very effective method, and I want to reiterate this because everyone who's over the age of 50, man and woman, must undergo colonoscopy at the minimum every 10 years, albeit it may be required to occur at an increased frequency if abnormalities are found. So let's say that, unfortunately, the cancer is identified, and what's to be done? Well, it turns out that about half of the cancer cases are early enough that it's either involving the colon or the colon and the regional lymph nodes, that surgery potentially has the ability to cure the person. And so it becomes important to attend to this fairly quickly, undergo effective surgery, and then at that point, depending on the findings, there may be a need for chemotherapy. So, for instance, if the cancer has been removed and the regional lymph nodes are sampled and it's found that the lymph nodes do have cancer in them, then we also know from a body of data that spans over 2 decades that giving the individual chemotherapy at that point will further reduce the chance of cancer coming back. And in essence, you have a very high chance of curing the individual even at a high stage. There is a subset of patients, probably accounts for about 10% of the colon cancer patients, that at presentation their cancer has already spread either outside of the colon to a nearby organ such as the liver or to the lung. And in that case, the cancer is not considered to be curable because it has already spread. But even when that happens, we've made quite a bit of strides in the past decade in the treatment of colon cancer in the field of medical oncology, and there's actually greater hope for these patients today. So just to talk briefly in general about this, because I think that's a group of patients that we all worry about. You know, the patients who have a localized cancer, they can go under surgery, and I would say about 80 to 95% of those patients are cured from surgery alone or a combination of surgery and chemotherapy. But it's that minority of patients who unfortunately present with advanced disease, metastatic disease, where surgery cannot be curative and we have to rely on chemotherapy. So, the point I want to make is that there's been a great deal of advancement in how we treat colon cancer in the field of medical oncology in the past decade. About 6 years ago, work that was done showed that if you add newer agents, so-called targeted therapies, that are very specific against the pathway by which the cancer works, for example, the pathway of growing blood vessels, you can actually improve on the effect of chemotherapy and improve the survival of the individual. So as a result of this, today when we treat advanced colon cancer, we not only give them chemotherapy, but we also use these targeted therapies. Some of them you may have heard of. There's a drug called bevacizumab, or more commonly known as Avastin, that is commonly used as part of the treatment, or the drug Erbitux, or cetuximab, that is also used along with chemotherapy to improve on the results. And more importantly, what has happened in the past 2 years is that not only we are getting better results with these newer drugs, but we are also identifying groups of patients that we can predict whether they're going to respond to these medications or not. So we're getting very smart in choosing the drugs for the specific patient. We just don't randomly give the drug to everyone. And this has also impacted our ability to improve the survival of patients. And I'm leaving out actually the great deal of research that is ongoing at major medical institutions in this country, including my own institution, looking at newer drugs, newer targeted therapies to try to improve on the results we have had. The other thing that I want to point out is that even in cases that the cancer has spread to an area outside and it is metastatic, there are select cases that if you actually remove the primary tumor and then you demonstrate that you can shrink the outside area, let's say if it's the tumor in the liver, you can actually go back in and remove that liver tumor as well and potentially cure the person. So I say this because I want to make sure that you realize that even in that advanced stage, cure is possible for some patients as well. So what I urge all my patients, and I urge you as well, is that if you are faced with such a diagnosis, of course you need to talk in detail with your physician about what needs to be done, the treatment options, but also seek a second opinion as well. And I don't think there is any physician here that would be upset or discouraged by this. I think it is within your right to seek a second opinion because there's always other avenues of treatment that may be right for you that needs to be explored, and you're never going to know about it unless you actually look into it. So the future is actually very bright for colon cancer, and I am personally hopeful based on what I have seen coming out of the laboratory and the trials that are being done on a national level, that we are going to have newer drugs that are going to be effective for this cancer, and we will certainly be able to further prolong the life of those patients who have advanced or metastatic colon cancer.